And it is now my pleasure to introduce Dr. Ruben Mesa. Dr. Ruben Mesa is actually visiting us from the Carolinas, from Atrium Health and the Wake Forest University. Again, you can look at his bio and his extensive work in the field, and I'm very excited to see what he has to share with us today. So, Dr. Mesa, the floor is yours.
Well, it's a huge pleasure to be here, and tremendous thanks to GAIF for both pulling this meeting together, as well as the long commitment really by CRT as well as Dr. Silver for really putting this as a resource for yourselves. You know, as those of us involved in caring for MPN patients for many years, you know, when you have a condition like this, there's just a lot of questions. You know, it's not a common disease. You know, you don't see it on The View. You know, it's not talked about on Oprah. You know, and so when you have an MPN, you have all these questions, but they don't really easily fit in a doctor's visit for many reasons, as well as sometimes really just all of you gathering together and learning from each other is such a powerful experience. So Dick and CRT really have been some of the leaders from the very beginning of really trying to bring folks together, bring together experts from a range of areas, and for those experts to both be a resource for yourself, but also to create a sense of community amongst yourselves. Now, one of the areas that's really arisen from, let's say, kind of a collaboration between the MPN research and physician community and yourselves as the patient community is a better understanding of what goes beyond the blood counts. What are the symptoms and impact on quality of life that having an MPN can have? How do we quantify that? How do we assess that in the setting of medical therapies, but also how else can you be empowered to try to feel better? You know, I frequently say, you know, I'm never going to be able to prescribe you enough pills to feel well. You know, you heard from the lovely talk from the cardiologist just before the break. You know, there is much that goes into feeling as well as we can. You know, and medicines will never be kind of a fully satisfying piece of that. Here are my disclosures. I've been involved with many trials. So one could say that I'm either heavily conflicted, or I like to say I'm equally conflicted, and that I pretty much have danced with everyone. So first, let's talk about symptoms and quality of life. Sometimes people say that they are the same thing, and they are not. Symptoms can impact your quality of life, but symptoms are a discrete entity in and of themselves. Now, what is quality of life? Is it a beautiful day? Absolutely outside. Is it spending time with friends or family? Quality of life sometimes is broadly described as where I think my life should be and where it is. So it is the ultimate subjective piece. You know, if you live in Minnesota and on a January day it gets up to 40, you might think that it's amazing. And if you're Miami and it's 40 degrees, you might think that it's horrible. There are many things that can impact quality of life that are not related to our health. And there are those things that can be health related. Now, symptoms clearly can play a part in this. And again, we know you have symptoms because you have told us. And those, one of the best kind of teachers in medical school I had along the way really shared, you have to listen to your patients. Listen to what people are telling you. And that will tell you a tremendous amount. So when someone walks in and I ask, really, how are they doing? I just kind of sit back and really allow that to kind of sink in. And again, you really get a sense of personal stressors. You might get a sense of this medication I'm taking is horrible, or I'm doing great. I'm really happy with how things are going. or something terrible happened in my life. My sister died of breast cancer. And it may not directly relate to their health, but it still is very, very relevant in terms of kind of what they're going through. Now, symptoms are very discrete aspects of how we feel that I'll share with you. We can both quantify and are linked to the biology of the disease that are both a sign of the illness as well as can be important things that we track in terms of the impact on your quality of life. Now, health-related quality of life includes our symptoms, but it's not limited to that. It's clearly if we give you a medication and the medication has, let's say it improves your itching, but it gives you diarrhea 10 times a day, the net impact is probably a negative. But it may depend on how bad that itching is. If the itching is bad enough, somebody say, okay, I'll go 10 times a day if I have to, but the itching was that bad. So it's always this calculus, if you would, of the good and the bad. It can include other things, the hassle of medical care. Again, I got to drive an hour once a week to go get a blood transfusion. And when I'm there, it takes 6 hours. That impacts my quality of life in a negative way. Or I have financial toxicity. The copay that I have for this medication, and I'm on a fixed income, is more than I can afford. And every month I get deeper into debt because I'm paying more for my medications than I can afford. So all of these things really impact this health-related quality of life. Now, our team in the Carolinas is very focused on thinking about kind of the breadth of what folks are going through. And weave into this both this concept of patient navigation, helping people kind of walk through their journey, as well as the issues of what folks face in terms of financial toxicity. Here earlier this year, we hosted the First Lady, Dr. Biden, as part of the Cancer Moonshot, and the director of the NCI, Dr. Kim Rathmel, highlighting some of these programs. And again, navigation has not been a big part of MPNs in the past, but I think it's an opportunity for us. It's something we've learned in solid tumors and advanced hematologic malignancies of helping to navigate through a challenging illness, helping to be connected with resources, helping to streamline coordination of care, depending upon the complexity an individual faces, as well as being mindful of issues of financial burden. We have a very strange system in the U.S. I'm sure Hans and his colleagues from Denmark come in are a bit dumbfounded when they come in and visit. We have medications that might be incredibly expensive, but if they're delivered in a doctor's office, might be free to you. But if it's instead a pill that you get at home, you might be on the hook for thousands of dollars a month. Doesn't make a lick of sense. Yet, it's something that we factor in as we really think about both financial toxicity as well as, again, look at issues of health policy as they relate to trying to care for patients. Now, circling back to MPNs, as you're hearing about today in the various talks and you hear about therapies and we have the breakout groups, MPN patients are a heterogeneous group. You look around this audience, you have people of all ages, backgrounds, ethnicities, and cultural experiences. And similarly, the impact can be quite variable, from early MPNs where we have difficulties with risk of blood clots or bleeding, and advanced MPNs where the diseases can be more life-threatening with further impact on low blood counts, anemia, enlargement of the spleen, or even risk of passing away. Now, one aspect that we have learned along the way is that both there are symptoms, but the symptoms can evolve. The symptoms can impact your quality of life. The symptoms can improve related to medications, and sometimes the symptoms can improve in non-medication or non-pharmacologic interventions, such as diet, exercise, yoga, or things of this nature. Now, there are many potential symptoms. These are some of the most common ones that patients have shared with us, but there are clearly many others, and any one individual patient, it is possible, might have any individual symptom. Now, when we first started doing this work, it really started because there was very active patients who came to us and really were bright individuals like yourselves. So again, bright, all the life experiences from their careers to their aspect of also being a patient in this community. And it was Joyce Niblack, who was, she was a chemist, she was an attorney, she was a patent attorney, very bright woman. And she challenged us and said, help us prove this case. She's like, because people will walk into a doctor's office, and because they don't physically look ill, compared to the poor individual with esophageal cancer in the waiting room next to them, their symptoms are just brushed away. As well, you can't be that bad off because the person that's on the next room is dying of pancreas cancer. And that may be true, but the fact that someone is more ill than you is completely irrelevant. Everyone is on their own journey, and it's not some sort of competition. You don't have to be the sickest person in the doctor's office to really merit care that is appropriate for you and where you are kind of in your journey. So when I visit with patients, and I think many of our wonderful colleagues really take the same sort of approach, Gaif, Naveen, Dr. Ritchie, so many experts that you'll hear from today, we think about many things. One, how has the MPN impacted them? Vascular events in the past, have you had a blood clot? Is there current issues from that? Low blood counts, big spleen, symptoms, is there risk of progression? And all of this, how this factors in the individual. If the individual also has other medical problems, they've had diabetes, hypertension, let's say they have 3 cardiac stents, on and on, all of these things are relevant, and you are not your disease. You are an individual. And even in terms of your health, it's really this calculus of all of these things put together. And to some degree, the better the rest of your health, the easier it is to put up with an MPN. So that's why things like diet, exercise, and being active, they matter anywhere you are along the spectrum, because the more you really improve what you can control, the more impact you really have. So let's just talk a moment about the biology of symptoms. So when we started this work, we really had some skeptics. We had some physicians, again, who would review papers and go, I saw an MPN patient once a few years ago, and in the 6 minutes that I spent with them, I did not get a lot of sense of their symptoms. So this survey that you have with 1,400 patients that have filled out an 80-question questionnaire, we're going to discount that because my own experience from that one patient really supersedes this well-done scientific study of 1,400 patients. Then there were others who said, I think the 1,400 patients, I think they're lying. I think they're just making this stuff up. Or, maybe they're all crazy. Maybe that's it. Maybe it is all related to anxiety. What we've learned is actually that symptoms have a real biological basis. They can be associated with inflammation. They can be associated with aspects of white blood cells. They can be the direct consequence of changes in the blood counts, the spleen, or others. Now, there was another patient, Zen Senyak, who we sadly lost to a gastrointestinal cancer, I think just late last year or early this year. And he challenged us in another way. He's like, symptoms have a basis in biology. However, don't discount the anxiety of having this kind of mystery illness that nobody knows what it is. That there's a stress and anxiety over the uncertainty that is real. And don't discount that either, because that itself may need therapy. Because I know what you guys go through. You see a friend and you tell them you have polycythemia vera, and you get the deer in the headlights look. Like, what the heck is that? And your friend either thinks, one, you're going to die tomorrow. Oh my God, let me carry that for you because I don't want you to die on the way to the table. while we're having dinner, or two, it's no big deal, because I haven't heard about it. So if I haven't heard about it, it can't be that serious. So that is a stressor in and of itself, that uncertainty, that anxiety. Because if you tell someone you have breast cancer, you have an immediate kind of supportive response of, oh my God, my mother had breast cancer, my sister, what can I do for you? And you tell them that you have something that they've never heard of, it's very awkward, at best. Now, the biology is real. Red is bad here, green is normal. Just to give you a sense, in myelofibrosis, the elevation in some of these inflammatory cytokines that Hans so nicely was describing as part of his discussion. And indeed, many of that inflammation and those cytokines, they have different impact on symptoms, progression, and even how the disease behaves. So we look at it a different way, and when we think about individual symptoms such as fatigue, which is the most common, we think about many pathways and cytokines that can be involved with that, as well as you see this and you realize, again, not only why is it common, but it's also sometimes very quite complex to resolve on its own. That any medical therapy is not necessarily going to be able to resolve all of these pieces. The same can be true with abdominal symptoms, for example. So the biology behind these things is quite complex. The spleen clearly can drive both common symptoms and increased symptoms, and sometimes even in patients with ET and PV, and not limited to those just with myelofibrosis. The constitutional symptoms and even microvascular symptoms, all having very complex pathways, cytokines, and biology. Symptoms have proven to be important in terms of predicting how threatening a disease is. And this is telling us a bit of a biomarker of the disease. Not all symptoms are the same. If someone tells me that they are having bone pain and disease-associated fever that they can tell from a thermometer, that for me is a concern about progression. Likewise, inadvertent weight loss. Nobody loses weight in our society without trying. Most of us try and can't lose weight. MPN patients will lose weight because of their disease, and they're still happy. But it's not a good sign. So again, this can have an impact on even the survival in the disease. Now, why do people progress? Another theme for today is that, one, that there's tremendous progress in MPNs, but two, there is really a risk of progression, and progression can really flow because of inflammation, increased genetic changes, and that for most MPN patients, if we can avoid progression, we can turn the disease into a chronic disease that will not shorten life. And then we can further focus on improving quality of life. Now, the measurement of symptoms we now have well validated. We have developed questionnaires that doctors use, that use in clinical trials, that we've now translated into many languages and used in many studies. And here showing in English and in Arabic, where we can look at individual symptoms and grade them from 0 to 10. And with this, we've identified, one, it's incredibly consistent, and two, interestingly, the ranking of symptoms by disease is almost the same globally. Fatigue being the worst, and that's true, and we have data from Madagascar or South Africa, Singapore, and clearly here in New York. Now, interestingly, the cultural piece is culture does impact on what score people tend to pick, so that certain cultures may have a higher number or a lower number kind of proportionally, but the ranking is the same. Now, when we use these things, everyone is kind of their own comparator. So if you start at a score of 30, decreasing to 15 is very impactful. And it's probably relatively equivalent to the person who starts at 60 and goes to 30. And there's a PhD out there in anthropology for someone who wants it. But the closer one gets to the Mediterranean, amazingly, the scores get higher. The closer one gets to Scandinavia, the scores get a little lower. So there is a cultural piece to the severity that is interesting. Now, one thing we've learned is that not only myelofibrosis patients are symptomatic. There's clearly symptoms in ET, there's clearly symptoms in P-Vera. Now, it doesn't mean that every patient has symptoms, but there are ET patients that have worse symptoms than myelofibrosis patients. Any one individual ET patient may have a lot of symptoms. Any one individual myelofibrosis patient may not necessarily have a lot of symptoms. So it is very individualized. So let me share with you a few lessons that we have learned. The first is that there is a clear difference between the general population and MPN patients. That was an initial criticism. You know, they say they're fatigued. I'm fatigued. Cry me a river. You know, we all have symptoms. There is a difference. Now, it is true that fatigue in the general public is higher than other symptoms as a baseline in the general public, but MPN patients still are yet another ratch higher. So we have learned that there are some subtleties in terms of fatigue. We've learned that the degree of symptoms does not necessarily equate the risk for MPN patients. The risk in ET and PV largely has been the risk of blood clots or bleeding, and that symptoms are not necessarily a surrogate for that. We've asked patients and physicians what is their primary goal of therapy. And for physicians, that primary one has really been the prevention of blood clots, as it has been with patients, but improvements in symptoms and quality of life being important amongst them as well. And in P-Vera and myelofibrosis, you have shared with us that your main goal is really the prevention of progression in the disease. Doesn't mean that you want symptoms or that they're not important, but it does challenge us that decreasing the risk of progression is important. And this has also been validated in US studies as well as those from overseas. And I'll certainly have Gabe be able to share these slides with individuals who want to realize there's a lot of information on these, and some of these might be helpful as kind of further background. Now, some other lessons we've learned, what is symptomatic enough to merit therapy? Again, for me, symptoms are the beginning of the discussion with the patient, not the deciders in and of themselves. Certain patients can tell me, my itching is bad enough that I want something to really try to change it. And others will say, I'm doing well enough at the moment. I really don't think I need therapy based on that aspect alone, but it might factor in with other risk factors we're trying to make an impact upon. This is the project that I had described along with Zensenyak, where we had done efforts looking at the impact of mood disorders and MPNs. And we did find, if screened for, there clearly are much higher than the general population risk of depression, anxiety, stress, and grief. And indeed have been able to correlate that with symptoms in a range of ways. We've identified that MPN patients, because of symptoms, sometimes will leave the workforce earlier, either through early retirement or medical disability. And this has included patients not only with MF, but also PV and ET. We have learned that there are clustering of symptoms, that certain symptoms travel together, and these are further biological clues as to the biology behind them. And we've also found clusters by disease itself. These are heat map type graphs where blue is without symptoms and red is highly symptomatic. And we're able to delineate some of the subtleties between pockets of ET and PV patients compared to those with MF and how these clusters are relevant. We have found that time is a factor in increasing symptoms. Again, probably not a surprise, but an issue with the progressive nature of the disease. We have found that there are gender-related differences, with certain symptoms being more common in female patients with MPNs for probably a variety of biological reasons. We have found higher rates of insomnia, and insomnia are likely probably exacerbating symptoms for a range of different reasons. We have found that there is an impact on intimacy. Number 2 symptom across the world, issues with intimacy. Again, largely not discussed in doctors' offices, largely because they really have not felt that they really had a tool to really battle against that. I frequently find that that's really a very helpful barometer. Somebody says, oh my God, doc, like I got night sweats, my spleen's big, I got a restless leg. I'm like, I'm not feeling very sexy tonight. On the flip side, I'm feeling well, I'm feeling rested, I'm feeling at peace. And intimacy, no matter where that kind of plays in my life, I feel that it is in balance. And that whatever expression that is for an individual is where they think that should be. It's an incredibly accurate barometer of does somebody really feel that they are where they should be. We've been able to show in complex analysis related to quality of life and things that impact quality of life that undertreated MPN symptoms and undiagnosed mood disorders can have the biggest negative impact on quality of life for patients with MPNs, as well as certain symptoms that were the most problematic. We've worked to have symptoms be a key part of how drugs are evaluated for impact and endpoints in clinical trials. And they have woven into both our treatment guidelines. If someone is sufficiently symptomatic, that can be a reason for the consideration of therapy. And in data that will be shared later with new therapies such as momelotinib. Let me just show you. This was the first trial to have really symptom response be kind of a key endpoint for individuals. We've also shown, again, comparing combinations of ruxolitinib and pelabresib. This will be more in Dr. Pemraju's talk, but where we look at symptoms and the impact of both spleen and symptoms in assessing response, as well as individual symptoms, as well as those that are combined. Now let me conclude with kind of the final piece. So what else can be done? Now there's an entire field now of what we call integrative oncology. Should I focus on diet, exercise, supplements? Should I focus on, interferon, JAK inhibitor, etc.? The reality is that there's probably some value really to both. And that you can do all the diet and exercise you want in the world, but if you need medical therapy, you still probably need medical therapy. And likewise, medical therapy rarely is a solution to, boy, I'm feeling as well as I possibly can. And integrative medicine tries to bring in both of these aspects. We did a survey along with my colleague who's now at City of Hope, Christina Gowan, who did a survey that really helped to find that many in MPNs are doing a range of different interventions, usually on their own, to try to have an impact on their symptoms. Physical activity, massage, yoga, nutrition, acupuncture, etc. Now, these sort of surveys, again, individuals that feel well enough are active in MPN communities to be online and fill out these surveys. There is some bias in that. Individuals are likely to be have higher income. They're likely to be higher educated. They're likely to have more discretionary time. So there are some biases to this higher level of participation, but still there are many helpful aspects that we have learned from this. One, without question, eating well is important. Now, everyone asks me, is there a specific diet? The answer to that largely is really not that we know of. We know that being on, individuals that are on any structured diet is probably better than not being on any diet. It means, again, people are paying attention to what they're eating, the balance of what they're eating, the quantity of what they're eating. If one were to take a kind of, in medicine, it's its own subset. There's probably the greatest degree of alignment around what we call the Mediterranean diet. It's a Mediterranean diet, some nice lean Greek food with a nice salad and a little feta cheese, or is it bukas? Probably more along the Greek restaurant. Heavy in fish, less red meat. Quantities are in balance. The quantity piece is important. A mix of fruits and vegetables, the olive oils, a little bit of red wine perhaps, but also includes all of this in moderation. Many of these things, again, have been helpful in helping to fight inflammation. And there have been efforts along Angela Fleischman, who's at UCI, has been a leader in this area, looking at both dietary interventions to try to have an impact. And she's had both animal models really of diet as well as these different interventions. Physical activity, without question, can be helpful for many reasons, as was discussed in the prior talk. Our group, we had focused on yoga as one type approach. Yoga has both a physical activity piece as well as a meditation piece. We had a specific intervention developed for MPN patients, and were able to demonstrate an improvement in inflammatory markers, sleep, and individual symptoms. Exercise prescriptions. Again, I think the most important piece is to do it along with your doctor's awareness and to start slow and take it very slowly. The majority of exercise arc in the US is January 1, I make my resolution. January 2, I have joined the gym. January 4th, I have an ankle sprain. January 5, I no longer go to the gym. And that's kind of the typical US arc that has been for exercise. Take it really slow, gentle, and for most folks, walking is really probably the cornerstone, where again, these other things I think really being helpful, resistance, etc., but even walking is kind of a key piece. Finally, other things clearly can make an impact. Acupuncture from really reputable providers for issues related to pain can make an effort. Supplements, a whole talk unto itself. I'm far from an expert in this area. I tend to take the approach, when you visit with your doctor, it's mainly to check, are the supplements I'm taking harmful? There is no good large data for us to really say, boy, you really got to be on this one. I'm sure any one of you have, but potentially one or others that you've taken say, boy, this really has worked great for me. And I say to that, fantastic. Like the moment we have an easy cure for these diseases, then we can be judgmental about other approaches. I'm like, until then, if you want to take curcumin, great. Do I know how much curcumin to take? Do I know how to optimize that? I don't think anyone does. In part, I think they're tricky to study. There's a lot of formulations. There's a lot of other variables. The efforts to try to have done this well has just been really, really complex. It's just complex biologically to really try to prove this. And then finally, I'll say that we're, again, actively taking lessons learned from MPNs and really trying to apply them in other areas, such as in meditation. So we have a study now across all heme malignancies. This is the National Cancer Institute funded trial of almost 500 individuals, trying to look at, with the app Calm, improvement in inflammation and sleep in a tracked way for people who have a hematologic malignancy but are on stable medical therapy. So let me leave you with these conclusions. Symptoms clearly can be linked to MPNs, are a sign of the biological aspect of the disease, and can be important considerations in considering both medical interventions and non-medical interventions. 2, not all the symptoms that you may have that arise in your life may be related to your MPN. They could be related to an undiagnosed mood disorder or a completely unrelated medical condition. But I think when you have an MPN, it's important that things in your health are really assessed through the lens of the MPN. Could this be related? Is it related? Is it a sign? Is it a sign of change? Does it impact the dose of the medication that I take? Could it be a toxicity from my medication? That's why it's an important thing to both actively track, as well as I think to have a very good, ongoing and honest conversation with your physician of how you're doing, what you're on, what you're doing to try to feel better, what's having an impact, so that you really partner together to really manage your MPN to the best degree that we can. In the end, everything we do in medicine can result in one of only two things. One, people can live longer, people can live better, or both. Everything else is just a surrogate marker of one of those two things. And with that, very much would like to thank the MPN community. Everything that I've shown you has really only been accomplished through the teamwork of the MPN community of physicians, of researchers, and patients. And then happy, I think we take questions later, but thank you so much.
Thank you, Dr. Mesa, for a fantastic talk. And actually, thank you for that very important slide where you show in your survey about what patients and physicians think important, that sometimes we agree and sometimes there's some discordance, but the thing that patients think is most important is what happens to their disease. Are they going to have progression or not?